Hi everyone, good morning. This is Ajasra. I'm one of those medical doctors here who's doing a rotation with Dr. Bernard and Dr. Stein for neuropsychiatry. And since we are in a neurology rotation and we're learning about this really complex organ, and all of us are actually aware about the intricacies and the complexities of the brain. So I thought I'd use this opportunity to talk about one particular part of that brain, which is called as the frontal lobe, which is also the biggest portion of the brain. And it's amazing how it's related to so many disorders and so many neurological disorders, so many psychiatric disorders, so many personality disorders. So I thought I'd go over a few of them. I can't go over all of them because it's beyond the scope of this presentation, but I'll try to talk about a little bit about the frontal brain, its anatomy, and the various disorders associated with it. What are the functions of the frontal brain? So let's get started. We'll start with overall just the brain. We've got the brain, which is like a 3 pound organ, and it's divided almost symmetrically into the left hemisphere as well as the right hemisphere. And both of these hemispheres are covered by cerebral cortex. Now, each cerebral cortex is then divided into lobes. We've got the frontal lobe, which is the topic of our discussion for today. Then we've got parietal lobe, we've got occipital lobe, temporal lobe. And then as we go down, we've got a small gland at the back, which is called as the cerebellum. And then we've got the brainstem, which then further progresses into the spinal cord. Um, I'm going to talk about a little bit about the properties and the functions of all the lobes before we get into the frontal lobe. So we're just a bit clear about how each lobe functions, what it contributes to our day-to-day activities, and the disorders associated with them. So let's start with that. So we've got the frontal lobe. Frontal lobe in general is associated with problem solving. It's associated with emotions because it has a heavy connection with the limbic system. It's associated with language production because, as we're all aware, the Broca center, which is also called as the motor speaking organ, is also there. We've got it's associated with inhibition. It's associated with giving personality traits to people. So that's about the frontal lobe. Coming next to the parietal lobe. Parietal lobe gives us a sense of touch. It gives us a sense of taste. It helps us to distinguish between the left and right of our body, to give like a spatial orientation around us. It helps in math calculations. It helps in doing day-to-day activities. And when the parietal lobe, the functioning of the parietal lobe is impaired, we can have something called as apraxia, which is to be more specific, constructional apraxia, which leads to people having difficulties doing day-to-day activities like buttoning up their shirts. It also helps in reading as well as writing. Below that, we've got the occipital lobe, which is also the most posterior part of the brain, which is involved in visual perception. It's involved in visual interpretation as well. I'm going to skip the cerebellum for now and come to the temporal lobe, and then we'll come to the cerebellum. So the temporal lobe also helps us in understanding language because this has the Wernicke's area, which helps in understanding what people are saying. It also helps in memory. It helps in language. It helps in musical memory, musical awareness, also formation of feelings. So that's temporal lobe. And then coming to cerebellum. Cerebellum helps us with coordination, balance, and equilibrium. And as we all know that if cerebellum is impaired, we can have things like nystagmus, we can have things like ataxia, dysarthria. So that's the function of cerebellum. And then as we go down to the brainstem, that the brainstem is divided into 3 parts. We've got the midbrain, we've got the pons and medulla. And I'm not going to go into detail about each of them individually, but in general, they just help in a sense of balance. They have a lot of reflexes. For example, the nerves that go through them, we have the pupillary reflex, we have the gag reflex. They also help in digestion because the vagus nerve goes down to the heart as well as the digestive tract and helps with that. It also helps in swallowing and in consciousness in general. So coming to the man of the hour, we're going to talk about frontal lobe. And the reason why I decided about specifically focusing this presentation on frontal lobe is because of this gentleman and because of this case, because this case had a tremendous influence on early neuropsychiatry. The Phineas Gage accident helped teach us that different parts of the brain play a role in different functions. And through studying Gage's frontal lobe damage, we gain better understanding of what the frontal lobe cortex does with regards to personality. Um, for people who might not be aware or are aware, I think it's a great case to discuss upon. This was a 24 to 25-year-old gentleman in the United States, and he worked in the railways. And whilst one day at work, when he was working, he met with an accident which led a tamping iron blow through his skull. As you can see on the picture, it went through his upper jaw, up pierced through his skull and came out through the frontal lobe, the left front, and he sustained left frontal brain injury. The surprising thing was that Phineas, after the injury, did not lose consciousness. He was walking, he was talking to people. He was taken to a doctor who examined him, who kept him under his supervision. And all of the treating doctors who could see him, saw him, could see that he didn't sustain a lot of focal neurological deficits, which would have been expected. But what was seen is dramatic personality change. So a bit background about Phineas was that Phineas was very friendly, very caring. But after the episode, people around him could notice certain change in his personality. He became more stubborn, lacked in consideration for others, had profane speech, and failed to execute his plans. So that was really interesting for neuropsychiatrists at that time to realize that they've got different parts of brain which control different things, and it's the frontal lobe actually which is responsible for a large part of our personality. And we're going to see as we continue through the presentation about few other disorders that happen. For example, frontotemporal dementia, in which one of the main symptoms is actually change in personality. So let's move forward and talk about a bit about the anatomy of the frontal lobe. I'm not going to go into too much depth. We're just going to discuss about how the frontal lobe is demarcated or separated from different lobes. For example, the frontal lobe, as you can see in the picture in the blue line is the central sulcus, which demarcates the frontal lobe from the parietal lobe. And then posterior-inferiorly, the temporal lobe is separated by the lateral sulcus, and then by the sylvial fissure, it is separated from the temporal lobe. The frontal lobe is roughly pyramidal in shape. So we'd say that it has three cortical surfaces. It's got the lateral surface. It's got the medial or also called as the interhemispheric surface, and it's called the inferior surface. The lateral surface is mainly supplied by the medial cerebral artery, and the medial surface and the anteromedial surface is supplied by the anterior cerebral artery. So now coming to the functional frontal lobe anatomy. Frontal lobe, as we discussed, it is a big part of the brain, and it in itself is divided into different cortex, depending on the function that they hold. So the most anterior part of the frontal cortex, it's called the prefrontal frontal cortex. Then we've got frontal eye field just behind that. We've got premotor cortex, primary motor cortex, which is the red area that you can see. And then we have the purple area, which is called as the Broca's area, which also helps in motor vocalization. Okay, so for motor cortex, we'll start. So everything before the prefrontal cortex, after the prefrontal cortex is called the motor cortex, and which is then later divided into primary motor cortex, premotor cortex, frontal eye field, and Broca's area. So we're going to start about talking with primary motor cortex. It receives inputs from thalamus and basal ganglia and sensory and premotor inputs, and then it sends out outputs to the brainstem and the spinal cord, which helps us in executing different movements. For example, me moving my hand is because of the primary motor cortex, because it executes the commands that were given to it by the thalamus and the basal ganglia. Any lesion in the primary motor cortex can end up having the patient having low or high tone, low power, and decrease in fine motor functions on the contralateral side of the affected side of the primary motor cortex. The second is the premotor cortex, which stores the motor programs and then controls coarse postural movements. So it actually gives output to the primary motor cortex and receives input from the thalamus, basal ganglia, and the sensory cortex. So if there is any lesion in the premotor cortex, it will lead to moderate weakness in proximal muscles, again, on the contralateral side. And then we've got the frontal eye fields. Frontal eye fields have they also give out input to the nucleus in pons, which is called as paramedian pontine reticular formation. It is also connected to the midbrain, which helps in vertical gaze. So it helps to select target and command movements to see towards where somebody is. If somebody is calling out to you, it helps you to look towards that side. If there is any lesion in the frontal eye field, and this is very interesting, is that if you have a destructive lesion, for example, a stroke, the eyes deviate towards the side of the lesion, that is, it deviates ipsilaterally. But if you have an irritating lesion, for example, a seizure, then the eyes will look contralaterally. It will look towards the seizing hand or the seizing leg, but not towards the seizing part of the brain. Then we have the Broca's area. It receives input from the Wernicke's and output is in the primary motor cortex, again, because it needs to give command to the primary motor cortex for the movement of your tongue, movement of your lips. The function is speech production in the dominant hemisphere, which for a right-handed person will be the left hemisphere, but for a left-handed person will be the right hemisphere. And in non-dominant part of it, it helps with emotional melodic component of speech. Lesions in the Broca's area can cause motor aphasia and also can cause monotone speech because, as we just read, in the non-dominant part of it, it controls your emotion, it controls the melodic component of your speech. So if that's lost, everybody will speak in a monotone, which is also a feature of Broca's speech area lesion. Now coming to prefrontal cortex. The prefrontal cortex in itself is divided into three parts. It's divided into the dorsolateral, orbitofrontal, and ventromedial. I'm not going to go separately into each of their functions, but I am going to combine them together, let you know how it helps, each part helps in some important functions in our day-to-day activities. For example, the orbital cortex, which is just in the front, which is the anterior most. This is a part of the limbic system, and this helps in emotional input and arousal. So any lesions in the orbitofrontal cortex can have emotional liability. It can lead to disinhibition. It can lead to distractibility, which again, as I had previously said, is a very prominent feature of frontotemporal dementia. Coming to ventromedial prefrontal cortex. This is quite heavily involved in motivation and initiation of activity. So if there is any lesion which affects the ventromedial prefrontal cortex, it can lead to the person having apathy, it can lead to decreased drive or awareness. And another very interesting thing is that a lesion in the ventromedial cortex can lead to akinetic mutism or abulia, which is basically limited verbal and motor responsiveness to the environment without actually losing consciousness or without having any paralysis or coma. This is quite often a result of frontal lobe injury, and a pattern of inhibitory control is one of which it increases passivity and gradually decreases speech and motion. And that's why it's called akinetic abulia mutism. And then lastly is dorsolateral prefrontal cortex. So the dorsolateral prefrontal cortex again helps in adjustment of behavior, plus it also helps in working memory. So it helps in executing executive function. So if there is a lesion in the dorsolateral prefrontal cortex, it will lead to decreased attention to relevant stimuli because it helps in working memory and executive functioning. So it will also impair people for people planning anything, for having emotional control over themselves, for time management, to have goals. So that's the sort of function that dorsolateral prefrontal cortex has. So this is just a summary of what I have said. It basically, all of these, a major part of the prefrontal cortex is to control your emotion, is to suppress distraction, arousal, motivation, initiation of activity, and just have help in executive functioning in our day-to-day lives. So the lesions in the prefrontal cortex can lead to emotional liability, disinhibition, distractibility, hyperkinesis, decrease in drive and awareness and spontaneous movements, akinetic abolic syndrome, which we just talked about, and mutism, disinterest and emotional reactivity. So this is just like a very concise picture about what the frontal lobe helps with, and if there are any lesions or if there is anything which impairs the functioning of the frontal lobe, people can quite commonly present with lowered libido. They can have weakness on one side of the face or body. They can come in with depression, behavioral changes, easy distractibility. All right. Again, this is just a little like a synopsis of all the changes that I talked about all the functioning of the frontal brain. And if somebody were to come in with having impairment of the frontal brain, this is the type of presentation it would usually look like. For example, a family member saying that the patient has had drastic change in their personality, because one of the other things which is quite common in a frontal lobe lesion or a frontal lobe impairment is that it leads to the person lacking insight into their own condition. So they usually do not present quite early to doctors, and it's usually people around them who see the change in their behavior, who see the change in their personality, who bring them in. So it will either be family members or somebody close to them, or at their workspace where they've become quite disinhibited. So people get a bit concerned about the change in personality. It can also lead to lack of initiation and spontaneity. Response is sluggish because, as we discussed, in the prefrontal cortex as well as the primary motor cortex, it helps in movement of the body. It also helps in planning the movement of the body. And occasionally, patient can be hyperactive and restless. Mood is often euphoric and out of keeping with the patient's situation. Irritability and outburst is common. Loss of finer senses and judgment is impaired. Okay, so now coming to the things that can actually cause the frontal lobe to malfunction or not function properly. We'll start with the first thing, which is traumatic brain injury. Anything from a gunshot wound or a closed head injury to contusions or hematomas can lead to impairment of the functioning of the frontal lobe. Frontal lobe is especially more vulnerable because of the widespread stretching during a closed head injury, because the brain is in a confined space in the skull. It can lead to shearing of the fibers throughout the frontal lobe. The second is frontal lobe seizures, which are very interesting because they're usually secondary to trauma, and they're quite difficult to diagnose. And they can be, because the presentation can be a little odd. These seizures, people who have these seizures usually present with uncontrollable laughter, crying, or verbal automatism, and complex gestures, for example, repetitive pelvic thrusting or fidgeting of their knees or their legs. So it's not quite easily picked up upon that somebody is actually having a seizure. Then it's associated with degenerative diseases, for example, Pick's disease, which is frontotemporal dementia, as well as Huntington's disease. It's associated with infectious diseases, for example, neurosyphilis and herpes simplex encephalitis. And then vascular diseases, as we had previously discussed. The medial frontal area is supplied by the anterior cerebral artery. So any territory infarction there can damage the medial frontal area. And the middle cerebral artery supplies the dorsolateral frontal area. And then any problems or the rupture of the anterior communicating artery aneurysm can also lead to personality change and emotional disturbance. Tumors, for example, gliomas or meningiomas, can also result in frontal lobe impairment and malfunctioning. And then multiple sclerosis. Frontal lobe is actually the second highest. Frontal lobe has the second highest number of plaques in multiple sclerosis. And these patients usually present with euphoric or depressed mood, memory problems, cognitive and behavioral effects. And then lastly, the psychiatric illnesses associated with frontal lobe is depression, schizophrenia, OCD, post-traumatic stress disorder, and attention deficit hyperactivity disorder. Another thing that I would like to add here is change in personality as well. So it's been quite researched from since 1800s about the association of frontal lobe malfunctioning or hypofunctioning in patients who have antisocial personality disorder. And once we get to the end of the presentation, I do have a little portion about that as well. So let's start with frontotemporal dementia, also called as fixed dementia. It is the third most common sort of dementia after Alzheimer's and Lewy body dementia. And it's actually seen a little earlier than Alzheimer's or Lewy body dementia. And it's the result of damage to neurons in the frontal and the temporal lobes of the brain. Many possible symptoms can result, including unusual behaviors, emotional problems, trouble communicating, difficulty with work, or difficulty with walking. And as I said, it tends to occur at a younger age than other forms of dementia. In contrast to Alzheimer's dementia, in which memory loss is usually the first symptom, the initial symptoms of frontotemporal lobe dementia often involve changes in personality, behavior, affective symptoms, and language function. Another difference on a more pathological level is that in Alzheimer's dementia, we see neurofibrillary tangles, which are called as tau proteins. We also see tau proteins in frontotemporal dementia, but they're not in tangles. They're round tau proteins, which are called as PIX bodies, and that's why it's also called as PIX dementia. And most patients with frontotemporal lobe dementia begin with language if it is affecting the left side of the frontal lobe, or emotional changes if it is affecting the right side of the frontal lobe. And the lack of insight seen in this dementia leads to patients to ignore or deny their deficits. And the core features, as divided by Neori criteria, are early decline in social and personal conduct, emotional blunting, and loss of insight. It's usually insidious. It doesn't progress very quickly. And the behavioral changes can be quite varied, as we discussed. It can go from people having disinhibition, but it can also lead to people having apathy, agitation, repetitive compulsive behaviors. And that's also one of the reasons why frontal lobe is associated with obsessive compulsive disorder. It usually lasts for 6 to 10 years because people do succumb to this dementia. And then SSRIs do help in some ways in improvement of the psychiatric function of the body of the patient, including irritability, depression, and repetitive behaviors. A little bit about aphasia, because as we discussed that Broca's or the expressive aphasia, the Broca's center is present in the frontal lobe. In any lesion of what is Broca's aphasia is a speech is effortful, and it is hard to convey your thoughts, but it to either orally, but as well as in writing. The patient usually knows what they want to say, but it's very difficult for them to convey what they want to say, as opposed to Wernicke's or receptive aphasia, where the patient speaks fluently, but it doesn't make any sense of what they're saying because the patients are having a hard time to process what the person in front of them is trying to say. So this is expressive aphasia, also known as Broca's aphasia, caused by damage in the anterior regions of the brain, and mainly the posterior inferior frontal gyrus, which is also known as the Broca's area. Speech is difficult to initiate. It's non-fluent, it's labored and halting. Similarly, writing is difficult as well. Language is reduced to disjointed words, and sentence construction is usually quite poor. Comprehension, on the other hand, is generally preserved because the arcuate fibers are preserved, as well as the Wernicke's area is preserved, which helps us to understand what the person in front of us is trying to say. So that's why it's only the person trying to express themselves that they can't express themselves as they would want, which seems to be very frustrating for the patients who have this problem. And residual deficits are usually seen. Coming to frontal lobe epilepsy, it is characterized by recurrent seizures arising from the frontal lobe. Frequently, seizure type are focal onset, so they do initially have consciousness, but then it sometimes can progress to bilateral tonic-clonic seizures. And status epilepticus may be associated more commonly with frontal lobe seizures than with seizures arising from any other part of the body or part of the brain. And frontal lobe seizures or frontal lobe epilepsy can be caused by abnormalities, as we previously discussed, like for tumors, any infarction, stroke, infection, or traumatic injuries to the brain's frontal lobe. The frontal lobe seizures are also associated with a very rare inherited disorder. It's called the autosomal dominant nocturnal frontal lobe epilepsy. And what patients It's not a very common disorder, but the few patients who have presented with this disorder have had quite frequent violent seizures during their sleep. And it involves complex motor movement of the patient as well as a lot of vocalizations, for example, shouting or crying or laughing, um, which is one of the reasons, as we had previously discussed, about frontal lobe epilepsy, which makes it a bit unique and makes it difficult for us as doctors to diagnose somebody to have frontal lobe epilepsy. So it can have head-eye movement to one side, complete or partial unresponsiveness or difficulty speaking, explosive screams, including profanities or laughter, normal body posturing, such as one arm extending while the other flexes, as if the person is posing like a fencer, and repetitive movements of different parts of the body. It can have rocking, bicycle pedaling, or pelvic thrusting. And because of this unusual behavior, as we previously said, it's not immediately recognizable as seizures. And again, they frequently are preceded by a somatosensory aura, and have complex behavioral events characterized by motor agitation and gestural automatisms. Schizophrenia and frontal lobe. Many patients with schizophrenia have shown clinical signs of frontal lobe dysfunction, including blunted affect, difficulty with problem solving, and impoverished thinking. It is mainly believed that frontal lobe has quite a lot of effect on the negative symptoms of schizophrenia. And the cognitive deficits in schizophrenia have been observed with neuropsychological tests of executive function, traditionally considered sensitive to frontal lobe damage. And these patients have seemed to have regular goal-oriented behaviors, impairment in goal-oriented behavior, impairment in planning abilities. And as we had previously discussed, that is actually one of the functions of the prefrontal cortex. It helps us to plan things. It helps us to orient ourselves to our surroundings, to have goals, to have a working memory. And then when if there is any improper functioning of this part of the frontal lobe, that can lead to these symptoms, which is also quite commonly seen in schizophrenia. On the other hand, negative symptoms of schizophrenia, as we discussed, are quite widely suspected to reflect a frontal lobe dysfunction. The functional neuroimaging demonstrated a reduced frontal blood flow relative to the general cerebral perfusion in patients with schizophrenia. So as you can see in this picture, and I'm sorry, it's a little hazy, but if you can see that the red, which is this is a PET scan. So the red is the uptake or the blood flow in that particular part of the brain. So it's quite active in a frontal lobe cortex in the control, which is, we would say somebody who does not have schizophrenia. But if we take it in comparison with a patient with schizophrenia, you can see less active in the frontal lobe and the cingulate gyrus. So this was quite a breakthrough for people to realize about the negative symptoms of schizophrenia. Also helps us in a way to see what we can do further to tackle the negative symptoms of schizophrenia, because it is quite well known that positive symptoms of schizophrenia are more easily treatable by pharmacotherapy, but it is the negative symptoms which are difficult to treat. And this breakthrough will help us a lot in treating those negative symptoms as well. Next, coming to depression in the frontal lobe. The prefrontal cortex has emerged as one of the regions most consistently impaired in major depressive disorder. Psychiatric patients classified as depressed demonstrate insufficient left frontal activation and arousal. And again, these patients present with lack of goals, lack of memory or working or planning things or having motivation to do day-to-day activities, which is one of the main features of depression. In severely depressed patients, demonstrate insufficient activation and a significantly lower integrated amplitude of the EEG evoked response over the left versus the right frontal lobe. And also one of the things that's quite commonly seen is that psychiatric patients classified as depressed have insufficient left frontal activation and arousal, which is the dominant part of the frontal lobe for a right-handed person. So as you can see, in a healthy patient, there was increased blood flow, or as we would say, normal blood flow to the frontal cortex. But in somebody who has chronic depression over the years, the frontal cortex, the blood flow to the frontal cortex is massively decreased, which again helps us to understand about the symptoms of a patient with major depressive disorder and how we can tackle those symptoms. We have obsessive compulsive disorder and frontal lobe, which we had discussed in frontotemporal dementia as well, that people with frontotemporal dementia, when the frontal lobe is affected, a lot of people present with repetitive movements or obsessions about certain things. And that's what actually led to more investigation into obsessive compulsive disorder and its association with any frontal lobe in functioning. So as you can see, as opposed to schizophrenia and depression, where the frontal lobe was not functioning or hypofunctioning, there is actually hyperactivity in patients with obsessive compulsive disorder in the frontal lobe. So you can see in the neuroimaging, it highlights that the prefrontal cortex hyperactivity associated with obsessive compulsive disorder. You can see the red part, which is more prominent in patients with obsessive compulsive disorder as compared to the control, and it's very, very less in the schizophrenia patient. And specific prefrontal cortical networks may be particularly responsible for the generation of these obsessive thoughts in obsessive compulsive disorder. Lastly, as I had previously discussed about the antisocial personality disorder and how it might some way be associated with the functioning of the frontal lobe, and these people having an impairment in their frontal lobes. So case studies as far as back as 1835 have reported the onset of antisocial personality traits after frontal lobe injury. Such cases typically involve damage to the orbitofrontal cortex, which clinical observation has associated with poor impulse control, explosive aggressive outbursts, inappropriate verbal lewdness, jocularity, and lack of interpersonal sensitivity, which sort of does describe somebody who would have an antisocial personality. And also describes it. It is also associated with conduct disorder in children. And such gross dysregulation of affect and behavior may occur in patients with antisocial personality disorder while their cognitive, motor, and sensory functioning remain the same. So that actually pinpoints it more towards why it might be associated with frontal lobe functioning and all the other lobes are functioning normally. So the patient can move on, have motor and normal motor and sensory functioning, but not have any behavioral conduct over themselves or dysregulation of the affect. So this was my presentation on different sorts of disorders associated with frontal lobe, a general anatomy of the frontal lobe, things that can lead to malfunctioning of the frontal lobe or lesions in the frontal lobe, and it's also very interesting to see how this one part of the brain has been associated with so many neurological, psychiatric, and personality disorders. And I think we have so much more to learn about the frontal lobe. But this is my presentation for today. Thank you very much.